So I'm talking in part as my role as a physician. I see probably between 30 to 60 pancreatic cancer patients a week. And some weeks we see out of them about 4 to 8 new patients. I've been doing primary pancreatic cancer for probably more than 15 years now. I've also discussed a little bit this with my nurse practitioner, so that there's a little bit of a more expansive thought process in how I answer this question. I think that for me, what is most prominent when I meet my patients is I would say the fear that accompanies our dialogue and our interaction, and this fear can make it hard to communicate with our patients, for them to understand what I'm saying, for them to comprehend. They listen, but it's very hard for them to comprehend because they're in such a state of fear. So it's fear, shock, denial, not so much anger or anything like that. It's just more like probably like I would say, out of all the emotional feelings that are transferred to me, I would say that fear is the most dominant at the initial diagnosis. And even people with very strong support systems, like very strong families or friends, or even people that have a lot of coping tools, that have gone through a lot in life, even in those patients, this is very evident. And this really impacts the ability for them to interact in our first meetings. So, two things that I've thought about, and I think that intuitively I've just done it through my practice over the years, is to remember for me in my mind, and I also reflect this to the patient, that we don't have to discuss everything in our first meeting. Not everything has to be discussed. So that's one thing that I have to also remember, because sometimes, we're so used to doing our work and we just continue speaking. We don't reflect on what we're saying. So that's the one thing. And the second thing, if my patients ask me very difficult questions, sometimes I can say to them as well that this is the first meeting. We don't have to ask and answer every question, and we can maybe go back to that question at a later date when we have more information about the biology of their tumor. So it's not that I'm not listening to them or not answering them the question, but not every question that is asked wants an answer. So like those are two things that I try to remember when I first meet my patients. I think really like dividing all the difficult information that we have. I think that's a big thing. So I don't want to carry on too long for this question. And so I think that because pancreatic cancer is such an emotionally exhausting diagnosis for the patients, the family, and also for the staff that are treating, I think that we have to take into consideration this cannot be a one-man team. It can't be one physician. I think this is from, most cancers, but I think particularly for pancreatic cancer, it's very evident that you need a nurse practitioner that has expertise in pancreatic cancer and the special needs of our patients, or social workers, psychiatrists, psychologists, this is case managers. So I think it's not so important how we call the people in the staff. I think it's just really important to acknowledge this cannot be a one-man show. Personally, I did it a lot by myself for many years. And when I think back, those were very traumatic years for me personally, when I think back about it. But I think also that I could never give my patients the kind of care that they're getting now, that we are a much more extensive team. We have a case manager that's only for pancreatic cancer patients. We have a nurse practitioner that is only for pancreatic cancer. And then we have psychologists and social workers that do all the cancers. And I think that for me, that is a key element. And I think that all of us have to try and approach this particularly challenging disease with this multidisciplinary team approach. And that will also facilitate to divide giving the information in a staggered way and not all in once by one person from one angle. So like, obviously, if you think about it, and this will be my last sentence, that as a physician, I have very particular things in my mind that I want to discuss with the patient, but a nurse practitioner has other things, and that is really valuable for the patient because of this fear that really predominantly will guide the effect of our first few visits very dominantly.
Anyway, I've been working with pancreatic cancer on and off for many years in different, from different perspectives. But if I'm thinking about my job as a nurse during treatment, one of the things that is sort of very much specific for this group is that, for example, many of them have become very sick without having so much symptoms, like it's been a silent disease until they come to us. They're quite sick already. Of course, not everyone, but many of our patients. And like you have, all the others of you have spoke about the shock and everything, but also that time is an essence. So I'm thinking, as a nurse, you need to really guide and coordinate, but also specific for this group, I think it's that you need to kind of offer support early, because many of my patients coming in with a pancreatic cancer diagnosis, they have had, like I said, symptoms, but quite diffuse for a long time. And also many of them have a lot of symptoms when we start treatment, and they get more symptoms during the treatment. And it's very hard for the patients to know, is this my disease? Is this the treatment? And I feel that to have kind of a relationship between the nurse and the patient is so important, because you have to build a trusting relationship in a way. Because also I note this, for example, patient coming into the emergency department where I work during treatment, they have been so sick from the treatment, but if they don't have someone they really dare to talk about everything with, it might not come forward, because also all the patients I have, they're so keen not to be too sick to get the treatment. So it's a specific situation, I think, for this group, because we don't have a huge amount of treatments to offer, even though things are progressing. So I think it's a sensitive and vulnerable situation, even under treatment. But on the other hand, during treatment, you have something to do. You have like a work that you go to your treatments, you're kind of having hope for this to help. But I think as a nurse, we need to prepare the patients for also, what happens next. And that is something I a little bit struggle with, because we focus a lot on the treatment, and then suddenly when you can't take the treatment anymore, time is short. So this is something I really think is important to think about. And I really agree with the previous speaker on being a team. I also think that, we have to involve the patients maybe more and ask what matters to you, and discuss the goal of the treatment is even more important for this group of patients, not only to prolong life or decrease symptoms. We have to take in the patient and ask what they want and what is important. So a teamwork is also crucial, of course. But for me as a nurse, I do feel that this group of patients is crucial to have a good continuity of staff. They should know us, and also a lot of time. I really think so.
Yeah.
Even though we don't have that, that's important. You cannot just build a new relationship with new people all the time, and usually the nurse is the sort of key here, I think. Yeah, I mean, in terms of emotional support, I think we need to be able to, be very, very easy to refer. If I have some patient that I feel she needs more than I can provide, then we need to have clear pathways to refer someone to maybe a counselor, or if you have a family that is suffering, you should have access to this. So the healthcare system needs to have a holistic, approach, and we should collaborate more, I think, with palliative care teams early, because even if the patient is not in a palliative late stage, they can have a lot of benefits from early supportive care and symptom management. So I would wish the healthcare system to be more coordinated and integrated in terms of the acute care and the palliative care. And I think this is particularly important for this group, from my perspective.
Thank you very much. First of all, I'd like to thank you for the invitation and to talk about my practice about this kind of subject. I'm working with Europa in Portugal. It's a Portuguese association that we help caregivers and patients with the disease, a digestive disease. And nowadays we have a support line for caregivers. So I'm going to talk about my experience, and I will give some tips that now normally we work with this kind of patients and with these caregivers. So first of all, normally the caregivers, they have own emotional health, and this important provider care is critical to preventing burnout and ensuring they can continue to provide the best care as possible. So the caregivers often become so focused on the needs of the person and they are caring for that they neglect their own well-being. So I'm going to give some tips, some strategies to help caregivers to prioritize their emotional health. So first is normalize self-care as a necessity. So the caregivers needs to understand that prioritizing their own emotional health isn't selfish, but essential. A caregiver who normally neglects their well-being is more prone to stress, burnout, physical illness, which ultimately affects their ability to provide quality care and encourage caregivers to recognize and name, for example, their emotions. It's important that first of all, they have to recognize their emotions and their thinkings. So emotions like guilt, frustration, sadness are common, but a knowledge of these feelings is a first step toward manage that effectively. The second tip and strategy that normally we work is promote healthy boundaries. Encourage caregivers to set boundaries and not take on too much. So it is okay to ask for help and recognize their own limits. So the caregivers need to learn how to communicate their needs and limitations effectively to both the person they are caring and their support of network too. Third, encourage self-compassion. Caregivers can be overwhelming and caregivers may feel like they are not doing enough. Encourage them to be kind to themselves and acknowledge that they are doing the best they can is crucial. Teach caregivers to practice self-compassion by being mindful of their needs and forgiving themselves when they fall short. For the strategy, provide education and research on caregiver health. Caregivers need to know how they are not alone and that their emotional health is just as important as physical care they provide. So provide resources of self-care strategies, warning signs of burnout and coping mechanisms can be a preventive measure. Another thing that is important is encourage regular breaks. So encourage caregivers to take a small breaks through the day. For example, 5 minutes to meditate, stretch, or take a small walk can help manage stress levels and prevent burnout. 6, another thing that is important is foster a healthy work-life balance. Normally, the caregivers should be encouraged to maintain hobbies or activities that bring them joy and relationship. For example, it's important to read, gardening, or painting. Having time for personal fulfillment is the key to the emotional health. For example, caregivers can be overwhelmed by the immediate demands of caregiving, but helping them set realistic expectations for the future is good. For example, long-term care planning is a good way to alleviate the stress. Another thing that normally can do is teach stress management techniques. For example, deep breathing, guided meditation, mindfulness can reduce stress, increase emotional resilience, and stay grounded. So encourage a regular physical activity, or even something as simple stretching or walking, as I told, can have a huge impact on mental well-being. Another thing that is important too is create a support system. Caregivers often benefit from connecting with others who understand their unique challenge. So support groups can provide emotional relief and a sense of community. So encourage caregivers to seek counseling or therapy can help them cope with stress, grief, and burnout. So here are some of several strategies that will help caregivers prioritize their emotional health. To help mitigate this kind of mitigate the emotional challenge that the caregivers normally have, we can have some practical support strategies. So you can implement to offer both immediate relief or a long-term emotional resilience. So one of the first that is very important is education training about their loved one's condition. So provide a caregiver with education about their loved one's condition, as well as caregiving skills, for example, managing the medical needs, navigating the healthcare system, can reduce stress and increase confidence. So feeling more equipped to handle caregiving challenge can alleviate anxiety and sense of helplessness. So knowledge is empowering and can help caregivers anticipate needs and reduce stress. So many, for example, nowadays, like many healthcare system from the Portuguese and a lot of associations, sometimes we have workshops, free caregiver workshops, or webinars like we have this one, to give some strategies that will help the patients to manage the care and understanding the medical equipment. Another thing that is important too is the time management and the task delegation. So caregivers often feel overwhelmed by the sheer number of tasks that they must manage. So help them create a realistic schedules and delegate tasks where possible can alleviate some of that pressure. So time management strategies allow caregivers to organize their day, prioritize tasks, and allocate specific times for self-care. So help caregivers develop a daily schedule, or for example, it's important to do some task lists. So, and it's important to give a caregivers to delegate responsibilities when possible, such asking family members for help with a specific task, or seeking out, for example, in a non-medical system or some neighbors, for example, and is a good way to manage the time. Another thing that is important is physical and emotional health support. Normally, the caregivers often neglect their own physical and emotional needs. So it's important to have a regular self-care activities, for example, physically and emotional healthy. So the regular self-care is important, as I told, reducing stress, improving emotional resilience, maintain overall health. And for example, it's not about grand gestures, but like to make some small habits, sustainable habits. So one thing that is important is they can encourage carers to set aside time for self-care, even just a few minutes each day. Simple practice like stretching, deep breathing, listening to music, that is very important too. We have a significant impact. Provide a fitness programs. Sometimes we have online, for example. So these also include regular check-ins with healthcare providers to address any caregiver special health concerns. Another thing is a social support. So it's important the family, the friends, the community, the network that they can have to make them feel less alone and more capable of manage their responsibilities. So it's important to encourage family members or close friends to take turns helping with caregiving tasks and simple offering emotional support. Another thing that is important, that is very important, encourage express writing is a good way to express and to write their emotions. And this is important because it can reduce stress, make sense of their experience, and they can expressive writing can serve as emotional outlet, allowing caregivers to write the frustrations, fears, and worries. It's like a sense of catharsis. Another thing that is important too is the technology tools. Nowadays we have a lot of technology. So we have, for example, they can use like medication reminders. We have a lot of apps, applications, and these tools can provide convenience and a peace of mind. As I told, it's important and caregiver support groups too, because they can talk about their experience. For example, Facebook, sometimes they have a lot of groups and they can contact which and can give to join local or online support groups, and they can talk with them. So, and they can interact, share advice, or provide a mutual support. Another thing that is important too is very important is when financial stress is a significant source of emotional strain for many caregivers. So connecting caregivers with resources for a financial assistance is very important too. So it's important to find a financial assistant can reduce the stress of managing caregiving costs, which can help caregivers feel more supported and less overwhelmed. For example, we have family caregiver support programs, for example. And I'm already finished. So another thing that we have here in Portugal, we have the respite care too. This provides a temporary relief for caregivers by allowing them to take a break from their caregiving duties. And the last one, if you need help, of course, you have to find a counseling and therapy because to manage the caregiving, such as grief, depression, and anxiety. So to finish, by offering a combination of these strategies, caregivers can experience a better emotional well-being, and they have a great sense of support, which in turn can enhance their ability to provide care.
Thanks, Louisa. Well, I think Helena spoke about this earlier, and I think this really is the key when we're thinking about that level of emotional support with this patient group. very difficult, complex symptoms, both physically, emotionally, and psychologically. We know about the higher levels of depression compared to other cancers. So I think the key is about early intervention of good palliative care early on in someone's diagnosis, because we know as well, because of the complexities of this disease, that things happen very quickly. So time is not on our side to provide support to these patients. So if we are involved in those teams that provide good emotional support, like palliative care teams, early on in that journey, it builds up trust with health professionals. You can develop those relationships early on. There was a study done a few years ago that looked at late referral into palliative care teams and how having to transition to a whole new team of health professionals could cause distress because the trust isn't there. They don't know these new health professionals. So I think that is really the most important point when we're looking at emotional support for end of life. And also because it gives people who are diagnosed and their families the opportunity to be able to talk about what's important to them at that point in their life. What do they want? What do they need? Where do they want to be? If we're not having those conversations earlier on, it can be quite difficult to have them at that point of end of life, because, as I say, things can happen quite quickly. So yeah, I think that is the biggest thing I would say to take away from that, is that early intervention. As health professionals, we need to be assessing the level of support that people need, so we know the whole range of emotions that has already been discussed. You know, the fear, the anxiety, the stress, the worry. We need to be able to distinguish which of those emotions need more of an intervention. So at what point do we involve psychological services? At what point do we need to look at medical treatments as well to support with someone's emotional and psychological needs? In terms of end of life as well, and this comes back to when we were talking about advanced care planning and making sure that we understand what someone's needs are, we need to be looking at spiritual and holistic needs. Have they been addressed? Have the people that need to be involved and had those conversations had the time to do that? Has it been spoken about? And something that we talk about a lot with people that we speak to here on the support line at Pancreatic Cancer UK is about anticipatory grief. So it's that emotion of how do you start to process what life is going to be like after death. So we talk about that a lot, and I think that's something as health professionals we really need to be aware of and be brave to have those conversations with people. I think sometimes as health professionals we shy away from having those conversations to try and protect people, but actually it's really important that space is given to be able to talk openly. I think someone touched on this earlier as well, but about providing that practical support and intervention for things that could be causing someone distress. So, for example, they might have concerns about finances, financial planning. Has that been addressed? Did the right people being involved to help to have those conversations? Again, I think sometimes we make assumptions about what's important to people at this time, and it's not always the things that we think it is. So it's important that the patient and the families lead on those conversations, and we shouldn't make assumptions about what those emotional support needs are. Yeah, absolutely. This is so important. And I do think it's something that we don't do very well sometimes. I think we can be wrapped up in prioritizing the person who has the cancer, which of course is important, but that can sometimes be at the detriment of the people behind them. And of course, I only spoke yesterday to a gentleman who was saying how he felt selfish, that he was worried about his anxiety, about how he was feeling about his wife. And I think, you know, it's trying to break down those emotional concerns that people have and normalizing it. You know, it isn't just about that person, it's about their whole family as well. I think we need to be upskilling our workforce with the right skills to support and recognise the needs of family members. You know, we need to be doing enhanced communication skills. We need to be empowering our health workforce to have difficult conversations. It's not an easy thing to do, but it's important. And we need to ensure that counselling and psychological support is available for everybody, particularly bereavement support, including children, and having those conversations with children, because it's here in the UK, we rely really heavily on charity input to provide those kind of services. There can be longer waiting times. So yeah, I think that's something that we need to address by upskilling our nurses and our doctors to be able to have those conversations with family members.
It's very easy to answer, but I would like first to say that I like the Lucia and her relation between depression and survival. It was very important.
Yes.
Talia, I hope to meet you in Israel. I am there often. And Helena, I'm sorry that I didn't meet you in KI because I need the emotional support there. Andrea gave us a lot of things too. And Nikki, I am not there yet, so I don't know. But my pancreas cancer started in Italy. And then I came to Karolinska, and they told me that it's inoperable, it's too big, and it's had spread to the vessels. So I never believed in doctors. So that's my philosophy. So I decided to go my own way. I decided to be open with my cancer to everyone I met. I didn't want to have any contacts with people who, and relatives also, and the family, who thought that the doctor, he was right. I will die within 6 to 9 months. And I wanted to be with positive person only. And I have the caregivers doesn't exist 7 years ago in Sweden. So my wife, she took care of me. And I have a very nice life today. And I can say that the first doctor who was empathic to me was Professor Marco Del Chiaro. Because I think all doctors should give some hint that they will do whatever they can to help the patient. I talk to patients every day or members, and they get the message that, oh, you have only 1 month or 10 months to live and so on. And that's incredible that it still go on like this. So Marco Del Chiaro gave me such a hope that he will try to operate me. No one could do it because it was too dangerous, too difficult. But he succeeded, and I live a fantastic life now with insulin and Creon. That's how I survive. And with my wife who helped me 24 hours a day. So that's fantastic. And I think that's very important. And I talk to many doctors that why don't you give a hope to every patient and not talk about the statistic. So far we haven't got any caregivers from the hospital or society. But now we start in Sweden to talk about that. We have organization for it. But in Palema, we have every second month, we have caregivers discussion with those who are involved in pancreas cancer. So that's how we do it in Palema. And I think this is a very important seminar. I would like to have it in Sweden too. Yeah, that was the first time I met Professor Marco Del Chiaro. All the other doctors said that it was no chance. I couldn't live so long time. But he said that he will try and do his best. And then that was fantastic. And then I met a doctor in when I took the chemotherapy. I did it in Stockholm, and it was during the summer. It was so bad organized, so I asked to go to another hospital. I got it in a small town north of Sweden, and they were very empathic and gave me a lot of hope when I was there. So that's something I remember very well. This person who gave me such a support.
Yeah.
And the interesting is that I have still this support from Marco Del Chiaro in Denver, where he is now, and all his colleagues in Sweden. I can contact immediately. Because in Sweden it's very difficult as it is in Italy. I live in Italy now. Here you can have contact with the doctors on the internet, on Facebook, and on everything, and they give an answer. In Sweden it's very, very difficult to get this help.